Alright, this is going to be Critical Care Pharmacology Part 5, and this is going to be anticoagulants and antiplatelet agents. Anticoagulants and antiplatelets prevent existing clots from enlarging and new ones from forming. They do not dissolve the clot. This would be the Fibrinolytics or the clot buster section. So in this section we're going to talk about very simply, the common pathway of forming clots and how these drugs intervene in the formation of clots. So let's talk about that just for a second before we get to the next slide. I like to look at this a little differently. And how I like to look at it is kind of building a wall. So to make a wall, essentially, we need certain components. And the certain components on that list are going to be bricks, mortar, and then to keep the wall up and running for long periods of time, I'm going to need emergency patches, if you will. So the bricks, sorry about the big letter there, the bricks are thrombin. The mortar that holds the bricks together is fibrin. And the emergency patches, in case we needed one, would be platelets. And if we think of it like this, then it's a lot easier for us to visualize where the medicine is actually working. So anytime that we adjust prothrombin to the forming of thrombin, we're talking about the actual thrombus or the bricks. One more time. Anytime the thing that we're talking about, the substance that holds the bricks together, we're talking about fibrinogen to fibrin. And anytime we're looking at cellular parts that would essentially provide quick emergency patches throughout the body for bleeding, then we would be talking about platelets and their adhesion or adherence properties. So bricks, mortar, or patches, and the bricks, thrombin, mortar, fibrin, patches, platelets. With that said, heparin sodium. Class on this is going to be anticoagulant. The action, it blocks the conversion of prothrombin to thrombin. So this is going to mix with bricks, and fibrinogen to fibrin. And this is also going to mess with the mortar. This is going to decrease your ability to make clots. It does nothing to the platelet or platelet aggregation. It essentially works on large substances like prothrombin to thrombin and fibrinogen to fibrin. Indications on this: prophylaxis in the treatment of pulmonary embolism in the patient with a new onset of AFib. We do not want them to form clots. If they form them on the left side, they'll generally either stroke out or have a heart attack. Diagnosis and treatment of acute chronic consumption coagulopathies, or DIC, disseminated intravascular coagulation. Prevention of clotting in arterial and cardiac surgery. Prophylaxis in the treatment of peripheral arterial embolisms. So if we have an arterial embolism where it's cutting off blood supply, this is going to be prophylaxis in the treatment of that. Or please, let's not have that. Let's try to get ahead of it. Contraindications on this: any known hypersensitivity, severe thrombocytopenia, which is low platelet count, active bleeding, bleeding disorders, recent surgery, blood dyscrasia, which means an alteration in the actual substances of the blood, where there be red blood cell malformation or low count, high white count, or low platelet count. Advanced liver and kidney disease, severe hypertension, suspected intracranial hemorrhage. Any of those are going to be a contraindication. Side effects: hemorrhage, thrombocytopenia, low platelets, chest pain, anaphylactoid reactions, and then bronchospasm. Dose on this, loading dose is going to be 5,000 to 7,500 units IV push. Maintenance infusion is based on the partial thromblastin time, and this is going to take a coagulation study. So this is generally done in a heparin sodium tube or a light blue tube. Special considerations on this: monitor the partial PTT levels frequently, especially after rebolus or adjusting the continuous infusion. Monitor for bleeding. Use protamine sulfate. This is going to be the antidote if we get too much heparin on board, as an antagonist in heparin overdosing. Guide use according to PTT levels. So we're going to base our entire adjustments of how much medication this person gets off of a coagulation study or a PTT level. Lovenox or Enoxaparin, class on this is going to be anticoagulant. It's low molecular weight heparin. Acts as a low molecular weight heparin with antithrombotic properties, has no effect on the PT, prothrombin. Does affect thrombin and activated thromboplastin time. So it does affect some of the ability to form an actual clot, but it doesn't actually work on prothrombin in general. It just hampers its ability to actually form a clot or a brick. Indications: antithrombotic agents following surgery, prophylaxis for deep vein thrombosis postoperatively, acute coronary syndromes, pulmonary emboli. Contraindications: drug hypersensitivity, active major bleeding, hemorrhage disorders, recent surgery, and then again some formed element in the blood that's out of balance or we have too much of, blood dyscrasis. Side effects: mild or severe allergic reactions, hemorrhage, thrombocytopenia, low platelet count, ecchymosis, bruising, or anemia. Dose on this for DVT prophylaxis is going to be 30 milligrams sub-Q BID, and acute coronary syndromes is going to be 1 milligram per kilogram sub-Q every 2 hours for 2 to 8 days. Special considerations: there is no antagonist available on this, so the protamine won't work on this. Monitor them for bleeding. PTT before administration so that we kind of get an idea of what their coagulation studies are before we initiate this. Use cautiously in patients with hypertension and GI disease, because if they have an active GI bleed or Mallory-Weiss tear or something like that, this is not going to be a healthy drug for them. Warfarin sodium, Coumadin class, blood former anticoagulant, oral anticoagulant. Action on this: depresses hepatic synthesis of vitamin K dependent coagulation factors. A lot of coagulation factors are vitamin K dependent. So what this is going to do is this is going to hamper the body's ability to form anything that would be utilized with vitamin K. Again, this is going to mess with the bricks, prothrombin to thrombin. Indications on this: prophylaxis and treatment of a DVT and pulmonary embolism, treatment of atrial fibrillation with embolization, coronary occlusion, TIA, prophylaxis in patients with prosthetic cardiac valves. So if they got an artificial valve in there, this is going to be prophylactic for them. Contraindications: known hypersensitivity, hemorrhagic tendencies, vitamin C or K deficiency, hemophilia, coagulation factor deficiencies, any kind of abnormal blood studies or blood dyscrasies, active bleeding, open wounds, extreme diastolic hypertension, cerebrovascular disease, pericarditis with an acute MI, severe hepatic or renal disease. If we start to think about that this can adjust blood coagulopathies, we can see very easily if they're actively bleeding, if they have coagulation factors that are not, if they're having any kind of stroke like diseases or have a tendency for a stroke or may have had a stroke, if their heart has a possibility of bleeding around the pericardial sac. Any of these would be devastating. Side effects: bleeding, abdominal pain and cramping, diarrhea, fatigue, nausea, fever, fluid retention, lethargy, and liver damage. Dose on this is going to be 50 milligrams IV push over 2 minutes. Special considerations: consult drug compatibility chart. This thing does not like to mix with quite a few drugs, so please do a compatibility check. Numerous medications react with warfarin. Use cautiously in patients with alcoholism, lactation, debilitation of any form, carcinoma or cancer, and congestive heart failure. Collagen diseases, hepatic and renal insufficiency, pancreatic disorders, vitamin K deficiency, hypothyroidism, hyperlipidemia, hypercholesterolemia, hereditary resistance to Coumadin therapy. So if mom and dad had tried this and it wasn't working too hot, please try to make note of that before initiating warfarin to someone. Integrilin, class on this, cardiovascular agent, antithrombotic agent, antiplatelet antibody, glyco-2b3a inhibitor. Actions, selectively blocks platelet glycoprotein 2b3a receptor, and this is like a super aspirin. This is going to stop the emergency patches from sticking together or aggregating. Indications, acute coronary syndrome, need for coronary intervention, percutaneous transluminal angioplasty or stenting. Contraindications on this, active pathological bleeding within 30 days, history of bleeding abnormalities, history of atrioventricular malformation of any sort, intracranial bleeding, brain tumor, history of recent trauma, uncontrolled hypertension with a systolic blood pressure greater than 200, or any kind of known hypersensitivity. Side effects on this are going to be bleeding, anemia, and thrombocytopenia. So low blood count, low platelet count, and essentially bleeding out. Dose on this, 180 micrograms per kilogram IV bolus upon diagnosis. Maintenance infusion of 2 mics per kilogram per minute for 72 to 96 hours. Special considerations on this is to monitor the patient for bleeding. Use cautiously in patients with renal insufficiency, failure, and those receiving oral anticoagulants or NSAIDs. NSAIDs generally also mess with the common pathway of clot formation in some form or fashion. ReoPro, class on this is going to be an anticoagulant, antithrombotic agent, antiplatelet agent. It's a glyco-2b3a inhibitor as well. Actions, selectively block platelets, glycoprotein 2b3a receptor, and again it inhibits platelet aggregation or the clumping together or the sticking together of platelets. Indications, acute coronary syndrome, the need for coronary intervention, PCTA, which is percutaneous transluminal angioplasty, or placing a stent, or stenting. Contraindications on this, active pathological bleeding within 30 days. History of bleeding abnormalities, history of AV malformation, intracranial bleeding, brain tumor, or history of recent trauma. Side effects, bleeding, including life-threatening hemorrhage, cardiac dysrhythmias, pardon me, bradycardia, AV blocks, atrial fibrillation, may precipitate hypotension and hematemesis. Dose on this, 0.25 milligrams per kilogram IV, administered over 10 to 60 minutes before the start of the intervention, and this would be if they went to PCTA or cath lab. Maintenance infusion of 10 milligrams per minute for 12 hours after the intervention. Special considerations, monitor them for bleeding, use cautiously in patients who weigh less than 75 kilograms. Older adults, anyone who has a history of GI disease, and a PTCA procedure lasting greater than 70 minutes. Do not agitate or shake the vial. Aggrastat, class anticoagulant, antiplatelet, glyco-2b3a inhibitor. Actions, selectively blocks platelets, glycoprotein 2b3a receptor, inhibits platelet aggregation. Again, blocks the sticking together of the emergency patches or the platelets. Indication, acute coronary syndrome, the need for coronary intervention, PCTA, or stenting. Contraindications on this, active pathological bleeding within 30 days, history of bleeding abnormalities, history of AV malformation, intracranial bleeding, brain tumor, history of recent trauma. Side effects, bleeding, vasovagal reaction, vertigo, bradycardia, anemia, and thrombocytopenia. Or again, low platelet count. Dosing on Aggrastat, 0.4 micrograms per kilogram per minute IV for 30 minutes. Maintenance dose of 0.1 micrograms per kilogram per minute, continuous infusion. Special considerations: monitor for bleeding and use cautiously in patients with platelet counts less than 150,000 per millimeters cubed. Plavix. Plavix is kind of like a super aspirin. Anticoagulant, antiplatelet agent. Actions: inhibit platelet aggregation of adenosine diphosphate to its platelet receptor, prevents activation of glycoprotein 2B3A complex, and prevents platelet aggregation. Indications: AMI, coronary intervention, cath lab or PCTA, angioplasty, or the risk of a CVA. Contraindications: hypersensitivity, active pathological bleeding, and lactating mothers. Side effects: life-threatening bleeding, hypertension, syncope, or palpitations. Dose on this: recent MI, 75 milligrams PO daily. In ACS, or acute coronary syndrome, active MI possibly, we give them 300 milligrams PO and then 75 milligrams after that daily. Special considerations: monitor for bleeding, avoid unnecessary invasive procedures, use cautiously in patients receiving other drugs that may induce gastrointestinal hemorrhage, show moderate concerns in patients with hepatic impairment. Fibrinolytics. Now, we already talked about the bricks, the mortar, and the emergency patches. In fibrinolytics, I want everyone to kind of understand here that the wall that we're building is to form a clot actually has a self-destruct mechanism in it. And the self-destruct mechanism is essentially plasminogen to plasmin. Anytime that we make the active form of plasmin, the wall or the clot will break down. Now, in the older days, we used to use things like TPA, and you may still use TPA today in some indications. TPA is tissue plasminogen activator. So the only thing that medication does is activate the plasminogen in the tissues. And once it's activated, it forms plasmin, which will break down the clot. Tenecteplase Recombinant, or TNCase. Class on this is an anticoagulant thrombolytic enzyme. Actions: activates plasminogen, converts to plasma. Now we're going to see this over and over again. Breaks down fibrin mesh that binds the clot, and the clot dissolves. Indications: acute myocardial infarction for TNCase. Contraindications: if they are actively bleeding, you are going to hamper their ability to clot. History of CVA: CNS surgery within the past 2 months, a neoplasm or new growth tumor, AV malformations, severe uncontrolled hypertension. Relative contraindications on this: recent major surgery, coronary artery bypass graft or a CABG, obstetrical delivery, organ biopsy, cerebrovascular disease, recent gastrointestinal or genitourinary bleeding, recent trauma, hypertension with a systolic blood pressure greater than 180 millimeters of mercury, or a diastolic pressure greater than 110 millimeters of mercury, high likelihood of left heart thrombosis, mitral stenosis with atrial fibrillation, acute pericarditis, subacute bacterial endocarditis, hemostatic defects, severe hepatic or renal disease, pregnancy, hemorrhagic ophthalmic conditions of any sort. If we're going to bleed into our eye or have the possibility of bleeding into our eye, this is not going to be a good drug. It's going to cause blindness. This will abolish any clots that you have present. Side effects: bleeding and reperfusion dysrhythmias. Let's talk about this here for a second. We get reperfusion dysrhythmias because all of a sudden we give everybody a fresh breath of air. Now the heart, every cell in the heart has the ability to generate its own stimulus and its own beat. So if we have a section of myocardium that's hypoxic and it's slowed down, it's not working as well as it should, and then all of a sudden we give it a nice breath of fresh air, it has the ability to initiate a contraction from that tissue, and it may do it out of turn. This may actually give us something called an RNT. It may give us VTAC or VFib. We need to be aware of this as we're reperfusing people. Cholesterol embolism may also be a side effect, which would be a fat embolism. Depending on where that's at, that may not be good for the organ. If it goes into the pulmonary trunk, it's going to be a PE. If it gets dislodged from the pulmonary side and gets run through the left side of the heart, it can easily be a stroke or a heart attack. Dose on this, administered IV push over 5 seconds. If they're less than 60 kilograms, 30 milligrams. 60 to 70 kilograms, 35 milligrams. 70 to 80 kilograms, 40. 80 to 90, 45. Greater than 90, we're going to give 50 milligrams of TNCase. Special considerations. Pardon. Screen carefully for contraindications and relative contraindications before administering. Monitor vital signs and cardiac rhythm. Perform baseline neurological assessment and reassessment every 15 minutes. Monitor closely for internal bleeding. If bleeding occurs, provide direct pressure to any vein and puncture site for a minimum of 5 minutes. Do not administer any other medication through the TNCase line. It likes life by itself. Do not mix it with any other meds in that line. Should be used with heparin sodium therapy. Antiplatelet Recombinant, Retivase. This is an anticoagulant thrombolytic. Actions: activates plasminogen and converts to plasmin. Again, we're seeing the same pattern here. Once we form plasmin, the clot is broken down. Breaks down fiber mesh that binds the clot, and the clot dissolves. Indications: acute myocardial infarction, active internal bleeding, history of CVA, CNS surgery within the past 2 months, new growth tumor, neoplasm, AV malformations, severe or uncontrolled hypertension. And any of these, all of these would be devastating. If they're having an internal bleed and they can't clot, and we just busted apart every clot that they had, the patient's pretty much going to die. If they have a history of a CVA, the area that's clotted off in there, or the tissue that has been affected by the CVA, may not reperfuse. It may actually give them a head bleed instead. CNS surgery, if they've already went in there surgically, the clots that have formed and the reparative tissues that are in play need to be left alone while they're repairing. Neoplasms, AV malformations, and then the hypertension. If you start a bleed, which people bleed all the time, it's just that our body and our clotting factor kind of comes to the rescue. And the person that we give this Retivase to, it will not be able to come to the rescue. Side effects: bleeding, reperfusion, dysrhythmias. This occurs from the same reason, given the heart, a big breath of air. Anemia. Dose on this is going to be 10 units IV over 2 minutes, and then repeat after 30 minutes. You should expect to see reperfusion dysrhythmias in the AMI case. Alteplase activase, class on this, anticoagulant, thrombolytic enzyme. Actions: activates plasminogen and converts to plasmin. Breaks down the fiber mesh that holds the clot together, and then the clot dissolves. Indications: acute myocardial infarction, acute ischemic stroke, acute pulmonary embolism. Contraindications: active internal bleeding, history of CVA, CNS hemorrhage within the past 2 months, recent trauma, AV malformation, bleeding disorders, or uncontrolled hypertension. Side effects: bleeding, reperfusion dysrhythmias, and anemia. Dose on this for the acute MI for weight greater than 67 kilograms, 15 milligrams IV over 2 minutes, 50 milligrams IV over the next 30 minutes, and then 35 milligrams IV over the next 60 minutes. Now this is going to come in 3 phases as far as the activase goes. For weight less than 67 kilograms, 15 milligrams IV push over 2 minutes, 0.75 milligrams per kilogram with a max of 50, IV push over the next 30 minutes, 0.5 milligrams per kilogram with a max of 35 milligrams, IV push over the next 60 minutes for ischemic stroke. 0.9 milligrams per kilogram IV with a 10% dose given as a bolus over 1 minute. So after we get the initial dosing on this, let's say that the person is 100 kilograms, 220 pounds, 10, 100, that's going to be 90 milligrams of Activase. So 10% of that would be 9 milligrams given as a bolus over a minute. Maximum dose is going to be 90 milligrams. Pulmonary embolism, if we see that, 100 milligrams IV over 2 hours. Nice and easy. We're going to want to reperfuse them. Special considerations on Activase. Screen carefully for contraindications and relative contraindications before administering. Monitor their vital signs and cardiac rhythm. Perform a baseline neurological assessment and reassess every 15 minutes. Monitor closely for internal bleeding. If bleeding occurs, provide direct pressure to any venipuncture site for a minimum of 5 minutes. Do not administer any other medications through the, and this is T in case, through the Activase line. Should also be used with heparin sodium therapy. That concludes part 5. If you have any questions, feel free to contact me. Name's Roy Smith, roy.smith@redlandscc.edu or smithr@emsa.net. Thank you.